Welcome. So, as a future clinician, you're trained to diagnose all the usual suspects, right? But what happens when the cause of an outbreak isn't natural? What if it's deliberate? Today, we're going to do a clinical primer on bioterrorism agents. And believe me, this is knowledge that could be absolutely critical in your career. Let's dive in. Okay, just imagine this scene for a second. Multiple patients show up at your hospital within just a few hours. They all have this strange descending paralysis. So what's on your differential? Is it Guillain-Barré, some weird viral encephalitis, or is it something else? This is the exact kind of scenario where thinking about bioterrorism isn't paranoia. It's just smart, astute clinical practice. So how do you even begin to tell the difference between a natural outbreak and a deliberate one? Well, it all starts with epidemiology. The key isn't just one patient's symptoms, but the pattern of the outbreak itself. Let's take a look at the clues that should really set off some alarm bells. Think about how this would actually play out. You might see something that looks like the flu, but is it way more severe than usual? Are you suddenly seeing a dozen cases in one day when you'd normally see maybe one a week? Are patients showing up with symptoms that just don't fit the classic textbook picture? Or hey, are all the cases weirdly clustered in, say, one single office building? These are the big red flags of a potential attack. Now, to help manage all these potential threats, the CDC has created a classification system. And this isn't just some academic exercise, it really helps public health officials prioritize resources and figure out how to respond. We're going to focus on the most dangerous category. So what makes an agent Class A? Well, it's this very specific, nasty combination of factors. They can be spread easily, a lot of times just through the air. They cause really high rates of death. And even a single case could cause widespread panic and completely disrupt society. Yeah, these are the worst of the worst, and the ones you absolutely, positively need to know about. And we'll start with probably the most infamous bioterrorism agent out there, anthrax. Its spores can be turned into an aerosol, which makes it an incredibly potent weapon. Under the microscope, Bacillus anthracis has this really distinct look. You can see these big, gram-positive rods that kind of look like they're linked together in chains. That's where they get the name boxcar shape. If you see this in a blood or spinal fluid sample from a patient with a suspicious illness, that is a huge diagnostic clue. And this slide right here perfectly shows the classic presentations. Over in panel C, you've got that painless black eschar from cutaneous anthrax, a really striking finding. But the one that screams bioterrorism event is in panel D, the chest x-ray showing that widened mediastinum. That's from hemorrhagic lymphadenopathy in inhalational anthrax. It is a hallmark sign. Let's just let that sink in for a moment. This isn't a suggestion, it's a public health mandate. Inhalational anthrax is so incredibly rare in nature that a single case is treated as an attack until you can prove it's not. Your job is to recognize it and make that call, fast. All right, next up, let's look at two other historical heavyweights, smallpox and plague. Both are highly contagious, and both have caused absolutely devastating pandemics in our history. You know, since routine vaccinations stopped way back in 1980, most of the world is now susceptible to smallpox. The key thing for diagnosis is the rash. Unlike chickenpox, where you see lesions in all different stages, with smallpox, all the lesions in one part of the body are at the same stage of development. They all evolve together, from spots to pustules to scabs. And here's the culprit for plague, Yersinia pestis. On this specific stain, you can see its classic safety pin look, where the dye gathers at the two ends of the bacterium. It's another one of those key microscopic findings you want to burn into your brain. Now, understanding how these two spread is just vital. Any case of smallpox is a global emergency, period. Why? Because the disease was eradicated. But with pneumonic plague, the immediate worry is person-to-person spread through respiratory droplets. And what that means for you is, the second you suspect it, that patient has to be put under droplet precautions to protect healthcare workers and everyone else. Next up is botulism. Now, this one's a little different. It's not an infection, it's an intoxication, caused by one of the most potent toxins known to humanity. So how do you spot it? Just remember the 4 Ds. These are the classic bulbar signs that show up early. It starts with the eyes, diplopia, and then it moves down, affecting speech, then voice, and finally swallowing. It's a really memorable and incredibly useful clinical mnemonic. And here is the clinical pearl that really helps you clinch the diagnosis. The paralysis descends symmetrically, from the head down. But notice what's missing. There's no fever. and the patient's mind is completely clear. They are awake and totally alert while their body becomes more and more paralyzed. It is a terrifying but very, very distinct clinical picture. To round out our tour of the Class A agents, we have two final groups to cover: tularemia and the viral hemorrhagic fevers. Tularemia can look a whole lot like a really bad case of pneumonia, with high fever and respiratory failure. The chest X-ray findings of infiltrates plus swollen hilar lymph nodes can be a big tip-off. For the viral hemorrhagic fevers, things like Ebola, you're looking for what starts as a nonspecific viral syndrome that then progresses to shock, and, this is crucial, signs of unexplained bleeding or bruising. And why are we so concerned about these VHS? Well, because without treatment, the mortality rate for some of these strains, like the Zaire Ebola virus, can hit a staggering 90%. That number alone just underscores how lethal these agents are and why we need to recognize and isolate them immediately. Okay, so we've covered a lot of ground on the agents themselves. But let's bring this all back to you, the clinician on the front lines. What is your role in all of this? Ultimately, it all comes down to this one thing: all the public health infrastructure, all the stockpiles of medicine, all the response plans. They are completely useless if the event is never even identified in the first place. You are the tip of the spear. Your diagnostic skill, your high index of suspicion, that is what triggers the entire response system. So as we wrap this up, I really want to leave you with this question. This isn't about being paranoid. It's about being prepared. Understanding these agents and how they present isn't just some academic exercise. It is a core competency for modern medicine, because when a crisis hits, you are the first and honestly the most important line of defense.